One second.
Oh, now we can hear you.
You can hear me?
Yeah.
Okay.
Welcome.
Thank you. So we'll go ahead. We're here from MGM Healthcare, Chennai. I don't know whether you can see our slides.
Yes, we can see.
First of all, thanks to Sushil and Srinivas Kumar. It's a big honor for us to be at TCT India. So thanks for the opportunity. Today, our task is to present electrosurgery in transcatheter valve therapy. We meant to demonstrate a lampoon with a valve in ring in the mitral position. We had a patient with dysfunctional mitral valve due to previous mitral valve repair from a 32 Edwards physio ring, and we meant to do a valve in ring with a lampoon. That was a task, but unfortunately the patient had fever and we had to cancel that procedure. But nevertheless, I thought we will demonstrate some electrosurgery procedures and also show the coaxial system that one needs. We get a lot of calls from various operators in India. How do you actually do the coaxial system? What catheters? Because many catheters are not available in India, and how do we do that? So I thought we will use this opportunity to showcase 2 or 3 live in a box electrosurgical cases all done here at MGM, and also showcase live on the catheter coaxial system. That's what we're going to do. So the first case you can see here is a patient with severe aortic stenosis. The echo is very obvious. Good LV. And in addition to aortic stenosis, the patient also had a fusiform aneurysm of the arch involving zone 2, zone 3. And also to the right-hand side of the CT image, you can see here there is a tight stenosis of the vein graft to the right coronary artery. To make things worse, his peripheral vessels were small, and it was 4 to 4.8, the smallest on the right, and the left was only 3.5. So you could argue you can put a TAVR, but we can't do a TVAR, and we wanted to do all 3 in the same sitting. So the access options, namely transfemoral, was not an option, because to do a TVAR, you need a 22 French, which is not going to go through. Left subclavian is an option, but you may only complete the TAVR, but not the TVAR. Transaortic was not an option because the bypass grafts were patent. So therefore, we decided to do a transcaval, and that's where electrosurgery comes into play. So stage 1 was to do a minimally invasive debranching of the arch vessels. And then stage 2 was to do a PCI, TAVI, TVAR, and close the aortic cable access. This is the schematic. The plan was to have the innominate fenestrated and the innominate from LCC to RCC, RCC to and then LSA was the surgical cut down done in a hybrid OR here. You can see here minimally invasive grafts from RCC to LCC, LCT to LSA. Now, next comes the fenestration of the endograft. This is done again in the cath lab. The endograft is unsheathed, and then a surgeon-made fenestration for the innominate is done, which is 8 millimeter, and this is just a demonstration of that. Once that is done, next we go to the axes. We get a venous axis, arterial axis, an aortogram and venogram. The idea is go into the vena cava from the IVC, puncture through the retroperitoneal space into the aorta, thereby allowing a large bore access into a large vessel, because we don't have a large enough vessel in the femorals. So after the aortogram, then we reconfirm a position using vessel navigator, where the CT images can be superimposed onto your fluoro so that you can be doubly sure that your catheters are in the right position. So we have a snare positioned in the aorta, and we have the coaxial system, which is the wire which is going to cut through from the IVC through the retroperitoneal space into the aorta. This is just the image for that. Here we make sure the positioning is such that we have a bullseye snare target in the aorta, so that we can receive the wire as soon as it enters the aorta. This wire is charged with diathermy, with a bovie, which we're going to demonstrate towards the end as how we do it. And because this diathermy, we're basically performing electrosurgery from the vein through the retroperitoneal space into the aorta. And once in the aorta, we have snared. Now we have a 014 access from the vein into the aorta with a 014 wire. Then we convert the 014 wire to a 035 wire either using a piggyback wire converter, or we use a microcatheter and a word catheter that I'm going to demonstrate here because we don't have piggyback available in India. For this case, of course, we had to import. So once we have the piggyback catheter, you can see here the microcatheter going in. Next, we exchange for an 035 Lundquist wire. And once you have a Lundquist wire, we take a 24 French large sheath going from the vein, i.e. IVC, to the retroperitoneal space into the aorta. And now you have a large bore access to the aorta. Next is standard technique. So of course, we perform the PCI, which is fairly straightforward. You can see here type A lesion, finish the PCI. Next, we swiftly moved on to the arch repair. The surgeon fenestrated arch graft was positioned. You can see here with the fenestration secured from the right brachial using a shuttle sheath. In the interest of time, I will just go very, very quickly. The arch graft was deployed. Once that's done, next comes the TAVR. And for the TAVR, of course, so the patient had severe AR with all the manipulation, so we had to be very quick. You can see here DSA showing severe AR. And next we took the aortic valve. Of course, you could argue, what do you do first? Do you do the TAVR first or the graft first? We thought we'll do the graft first, because if you do the TAVI, then the graft nose cone can go and disrupt the TAVR valve, hence the sequence. So now the graft was done, and after the graft and the TAVI was done, the aortogram was pleasing. You can see here a beautiful result and a nice demonstration of the fenestration leading to a flow into the RCC, then into the LCC, and then into the LSA. Now comes the last bit, which is to close the hole that we made in the aorta. You could either use a PDA plug. We chose to use a covered stent. So we put a fluency covered stent whereby the stent is deployed at the same time as the sheath being pulled out. And that finished the procedure, and the final aortogram was pleasing. And that was, in fact, first in man, TAVR, TVAR, and PCI proof of concept through a transcable. So we published it in the European Heart Journal. Case 2 will be another electrosurgery case. This is a valve-in-valve case because of dysfunctional magna valve in the aortic position. The patient had a 19 millimeter magna, therefore the ID was 17 millimeter. The left coronary height was 4.5 and the VTC was less than a millimeter. So a perfect recipe for left coronary occlusion. And this is what one would expect when you do a valve-in-valve, be it a balloon expandable or a self-expandable. Then the entire previous surgical bioprosthetic valve becomes a covered stent. As a result, if you have a very short distance between the valve and the coronary, you're going to occlude the coronary. This is the CT of that patient showing an ID of 202 millimeters. This is the left coronary height. We've been generous here. In fact, it's only about 4 millimeter, I would say, the left coronary. And you can see here the short axis, the VTC distance is extremely small. This is a stretched view where you can see there's hardly any space. And not only are we going to have an occlusion just by putting the valve, we also intend to fracture the previous valve, because the ID of 17, we put a 20 valve, we're going to have a huge gradient. So we intend to fracture the valve, which is make it even bigger, which means with this VTC, it's only going to get even wider, and the chance of coronary obstruction was almost certain. Of course, what are the options? The conventional technique has been doing a chimney. You can put a stent, very well established, and that works perfectly fine too. But then chimney stents come with their own problems. You can have a stent problem, and then it's a nightmare to get back in there. So we decided to do a basilica, which is another electrosurgery where you cut off the bioprosthetic leaflet, as shown on the bottom, thereby cutting off the covered stent portion, thereby allowing diastolic flow into the coronary. This is a cartoon. On the left-hand side is a normal wide sinus where you have a bioprosthetic valve that's been converted into a covered stent with a valve-in-valve, but then there's enough space, and therefore you're going to have coronary flow. On the middle is a narrow sinus where everything is obstructed, and therefore you're not going to have any diastolic flow. On the right-hand side, now the valve is cut off using basilica, and even though the sinus is narrow, you're going to have diastolic flow through the cut, and that's what we meant to materialize interventionally. And how do we do that? This is a cartoon to demonstrate, but we'll show you the real case. Here we have positioned the catheters. Basically, we need to cut off the left coronary leaflet of the bioprosthetic valve. We're not cutting it off, we're actually slicing it. And it's not a barbaric pull, it's going to be a neat cut because we're going to do an electrosurgery, not rip it off. And how do we do that? We have two catheters, one in the LV with a snare and one in the aorta, an AL1 with a microcatheter and an acetato wire. We're going to show the setup very, very shortly. And here we're going to make sure, same as what you saw in the transcaval system, we have a bullseye target. We have the snare position, the LVOT, ready to receive the wire exactly as it comes through the valve leaflet into the LVOT. And we're checking it in multiple views. Of course, we're using fluoroscopy and also we're using a heart navigator to have an added imaging modality to be sure on where we are. You can see here we are checking that we are indeed going to cut through the left coronary leaflet by injecting some contrast. You can see here we're just next to it. Again, multiple projections to be absolutely sure because we really don't want to get the leaflet wrong, and we did want to make sure the bullseye target is perfect. Once that's there, then we charge the wire, which we're going to demonstrate live now, and then go through, and the snare is the snare has received the wire, and now we snare it. Once we snare it, then we have a Owen 4 loop through and through the leaflet. Then again, you charge the wire and then slice the leaflet. And this is the actual setup here. My colleague, Dr. Anantharaman, is here. He's got the bovie. You can see here the bovie is being connected, which again, I'm going to show you here live how we do it. And then I'm going to pull on two ends of the Owen 4 catheter. We got the anesthetist ready because we expect severe AR after this, and we should be in a position to take the valve quickly. So we make sure the valve is loaded, E-sheath is ready, because once this is cut, we need to be quickly back into the annulus with a loaded valve. There you go. He's now cutting, and now I've cut it off. Once done, then as expected, there is severe AR, you can see here, but quickly we'll remove the lampoon system, get an E-sheath, get the valve in. Here we managed to get everything less than 90 seconds. And once that is there, standard TAVI deployment. But remember, this is TAVI deployment is undersized because we're going to put a 20 valve into a 17 ID. And next we go with an Atlas 20 millimeter balloon to fracture the bioprosthetic frame to try and get no gradients. And that's what we did. So this is just a snapshot of what we did, which is identify the ostium, wire through the leaflet, snare it in the LVOT, then you create an Owen 4 through and through, and then cut, and then the valve. And once all is done, here you can see fine lettergram, pleasing results, no AR, and good flow into the coronary. And again, echo showed near laminar flow, no AR, and gradient was 3.4, suggesting no patient prosthetic mismatch. And this is here electrosurgery with Basilica, 2-year follow-up of India's first Basilica. So they work with a very good follow-up. Third case and the last case.
Can we maybe stop here for a minute? I think we have to go to the live case site again, but and we can come back with time with this. But, I think you've highlighted some very sort of complex procedures. I think it's important to state that these are still, for the most part, off-label and really should be limited to extreme cases. And I think it's an important point to highlight. In someone, we also do these cases, but really in patients that are not surgical candidates, because there are complications, and there's a lot of stuff, and it's complex. And although the techniques have really been refined by the group at Emory and at NIH, there's still a lot of issues that can occur, and I think it's important to sort of emphasize.
Sure, absolutely. Couldn't agree more. This is not something we expect to do on a regular basis. We probably will do this perhaps once in 3-4 years, because I can't imagine this day and age we're going to have a patient with poor access that we need a transcaval regularly, as you very rightly said. But do we have time to show the actual kit? Because I thought we have another 10 minutes on here. Am I right?
Gopi, Anand here. Can you hear me?
Anand, yeah, hi.
Nice to see you, bro. Nice to see you.
Hi.
Those cases brings back lots of memories.
Sure.
I think what they want to do is, because the case, the mitral clip case some issues as they want to go and come back and
Okay.
then just continue with you.
Shall we wait here and then wait for
Yeah,
you to come
yeah,
back?
please
All right,
wait.
we'll wait.
We'll come back
Off you
and
go.
see the demonstration.
And then we have the demonstration ready.
Yeah,
We'll
yeah.
show that. All right.
Sure.
Srinivas, can we switch?
Can we get back to
Okay.
Gopal? Yeah,
Okay.
Gopal, we're back with you. Can you hear us?
Hear you. You can hear me?
Yes.
All right. I'm told we have another 9 minutes. We should finish in 6-7 minutes. So the last case, we'll just show a lampoon and then we'll show the kit. So this is a lady with severe MS and MR with MAC and were declared not fit for surgery and TMVR. I'll tell you why TMVR was also not suitable initially. This is the MAC. You can see the MAC, significant calcification. There you go. You can see the MAC in the non-contrast views. And this is our analysis. You can see here a 29 valve, which we want to put in this MAC, had a significant risk of LVOT obstruction and AML, including the whole LVOT. And this is the VR, virtual implantation. You can see here there was a risk of embolization because the MAC was not adequate. This was done at Edwards' core lab, and there was significant risk of LVOT obstruction, almost 90 to 100% chance, and that's why TMVR was also deemed not suitable. So the major issues were valve embolization, LVOT obstruction, significant PVL, but the patient had no other option. She was not a surgical option and pretty much prohibitive risk. So we decided to do a TMVR using MAC as a landing zone. The plan to prevent embolization was to intentionally overdilate. And of course, LVOT obstruction is going to happen. We're going to lacerate the AML with lampoon and also have percutaneous ECMO and use a special kissing balloon inflation, which has been described before. We named it KIBAM to try and align the mitral valve away from the LVOT, which I will show in a second. Of course, all this fails. The plan was to do a last resort surgical option. So lampoon, this is the cartoon for those of you who may not be familiar. The idea was to lacerate the AML, like how we lacerated the aortic leaflet in a basilica. So 2 JL35 guides, one for a snare and one for the charged wire, cut through the AML, create a loop, and then cut the AML. And by doing that, the final result I will show, one gets a valve like this. You can see here on the left-hand side, this is without lampoon, where you're going to obstruct the LVOT because of the AML. On the right-hand side with the lampoon, because it's cut, it's going to allow flow. And this is the transeptal that we did. And this is the actual case where you can see here lots of catheters, multiple wires, but essentially 2 JL35 guides retrograde through the aorta, through the aortic valve, one positioned in the LA with a snare, and the other at the base of the AML, ready to take a charge wire through the AML. And here you can see the charged wire has gone through. We're going to show that in the next minute or two live. And this is the echo correlate. You can see here the snare in the LVOT. And here in the 5-chamber view, you can see the other JR35 guide ready to poke through the base of the AML. And once that is done, next the valve goes in. And the valve going in, this is the special maneuver that we brought in, which is KIBAM, which is kissing balloon inflation of the aortic and mitral. And the idea is, if you have a balloon in the LVOT, then the mitral valve is likely to align away from that LVOT, and therefore the less chance of LVOT obstruction. And it proved a good idea in this case. So you can see here, prolonged inflation. We have ECMO on standby, which is also running to allow this prolonged inflation. And we're trying to position this mitral valve with the inflated LVOT balloon. And once that was done, it was implanted. We did not come off pacing just to be sure that we have absolute anchoring. The anchorage was adequate, but then there was significant MR because the mitral valve was slightly more atrial than what we'd like, and therefore there was in-out MR. And to address that, we decided to put a second valve. And the second valve, in the interest of time, I'll go in very quickly. The second valve was put in just 5 millimeter more ventricular, and that stopped the in-out MR and had a very good result, fairly laminar flow, and 2 valves there, and patient did very well. And this is a week after. Transthoracic echo showed fairly laminar flow. There was no MR, and the aortic valve, there was no gradient at all. This is the mitral, again, no MR. That was artifact that you see on the left-hand side. And the mitral gradient, mean gradient was 6, and the aortic mean gradient was 8. And she's just reached 1 year follow-up, and we hope to publish this in the near future. So how to do electrosurgery? Let's move the camera to the actual table. This is the coaxial system that a lot of people have asked, so I thought we should demonstrate here. So I hope you can see here the way we do this coaxial system. In India, there is no wire converter, i.e. piggyback converter from Teleflex is not available. So what we've done is, this is a JR guide. Into a JR guide, we have put a 4 French vertebral catheter. Into the 4 French vertebral catheter is a fine cross microcatheter, and through the microcatheter is an Astato 20 wire. So I hope this makes sense. This is the coaxial system. And to the other end, you can see here the end of the wire, the Astato wire. This is the end of the Astato wire. You can see here that's connected onto the Bowie and then clipped on. Yeah, I hope that is very, very clear, and that's ready. And once we press the button to diathermy the end of the wire, it'll get charged and it'll go through tissue. And I want you to come back here, and I hope you can see here the charge system. Can you see here? Light off, please. Right, okay. Charge.
Yeah.
Okay, stop. So that was just through a piece of meat, a chicken breast, so that you can see how this comes through. And once that comes through, everything will just fly in. You can snare it here on the other end and then take it forward. And once you snare it and take it, you can see the fine cross will go through, and through the fine cross, again, the multipurpose, no, not the multipurpose, I mean the vert will easily come through.
Yeah. No, I think this is a great improvisation using the equipment that we have.
So that's just to demonstrate, because we don't have the piggyback wire converter. I think this is a good way where one can use this, not just for transcable and also for congenital cases via to pulmonary windows. So I hope these 3 examples, Lampoon, Basilica, and transcable, demonstrated some electrosurgery, and this was useful. Thank you. And we'll take questions if there's any time.
Thank you so much. I think we have to move on because they're ready for deployment in Chennai. So thank you again. This is a great demonstration.
All right, thanks.
Thank you.